Clinical case vignette, Addison's disease. A 38-year-old woman presents to the emergency department with fatigue, weight loss, nausea, vomiting, and dizziness for the past few months. She reports increasing skin pigmentation despite avoiding sun exposure. On examination, she is hypertensive, BP 85-60 mm Hz, has hyperpigmentation of the buccal mucosa and palmar creases, and shows signs of dehydration. Laboratory results reveal serum sodium 128 mg/L, serum potassium 5.8 mg/L, serum glucose 65 mg/dL, plasma cortisol 2.1 mg normal 6 to 23 feed, ACTH level 150 pg/ml elevated. The patient is diagnosed with primary adrenal insufficiency, Addison's disease. Question 1. Which of the following best explains the cause of this patient's hyperpigmentation? A. Increased melanocyte activity due to chronic sun exposure. Increased ACTH stimulation of melanocortin receptors. C. Direct stimulation of melanocytes by cortisol. D. Autoimmune destruction of melanocytes leading to paradoxical pigmentation. Answer. Rationale. In Addison's disease, adrenal failure leads to low cortisol, which triggers increased ACTH secretion. ACTH stimulates melanocortin receptors, leading to hyperpigmentation, particularly in sun-exposed areas, mucosa and skin folds. Question 2. What is the most appropriate and initial treatment for this patient in the emergency setting? A. Oral hydrocortisone and fludrocortisone. B. IV normal saline and IV hydrocortisone. C. IV dextrose with subcutaneous insulin, levothyroxine and fluid restriction. Answer. Rationale. The patient is in an adrenal crisis requiring immediate IV hydrocortisone and IV saline to correct hypotension, dehydration, and electrolyte abnormalities. Oral steroids A are used in stable cases. Insulin C is not indicated as the hyperkalemia is due to aldosterone deficiency. Question 3. Which of the following findings would be expected in a patient with secondary adrenal insufficiency but not in primary adrenal insufficiency? A. Low cortisol with low ACTH. B. Hyperkalemia. C. Skin hyperpigmentation. D. Metabolic acidosis. Rationale. Secondary adrenal insufficiency due to pituitary dysfunction leads to low ACTH and low cortisol. Unlike primary adrenal insufficiency, aldosterone production is preserved, so hyperkalemia and metabolic acidosis do not occur. Hyperpigmentation is also absent due to low ACTH levels. Question 4. A patient with Addison's disease is undergoing surgery. What adjustment should be made to their glucocorticoid regimen? A. No change in their daily steroid dose. B. Increase glucocorticoid dose before and after surgery. C. Discontinue steroids to prevent adrenal suppression. D. Switch to mineralocorticoid-only therapy perioperatively. Answer. Rationale. Patients with adrenal insufficiency require stress-dose glucocorticoids during surgery or illness to prevent adrenal crisis. This involves increasing their steroid dose before and after surgery, as the body cannot mount an adequate stress response. Let me know if you need modifications or additional questions.